sir, I can hear you.
Yes, sir, we can hear you properly, sir.
Yeah, I can hear you properly, sir.
Chan, can you hear me?
Yes, sir, I can hear you. I can hear you, sir. Sir, I can hear you. Hello, hello.
I can hear you. Okay.
Sir, could you please share your slide? Yeah. So, yeah, I think so, sir. You are talking about. Sir, could you hear me? Could you hear me? Sir, could you hear me?
Sir, we are able to see your screen, so we can directly share the presentation, sir. We are able to see the screen. Yeah.
Chan, can you hear me now?
Yeah, I can hear you, sir. Could you hear me?
হ্যাঁ চান শোনা যাচ্ছে না শুনতে পাচ্ছেন না ওখানে না না শুনতে পাচ্ছি না কেন হচ্ছে বুঝতে পারছি না আরেকবার দেখে বাকি সবাইকে শুনতে পাচ্ছেন তো আমি তাহলে কানেক্ট করব ঠিক আছে ঠিক ওকে ঠিক ঠিক ওকে
Hello.
So we can hear you, sir, properly.
Will be joining soon. There is some technical glitch, so we lost him. He will be joining very soon. Yes, sir. You have joined, sir? Yeah. Yes.
can you hear me now
Yeah. Could you hear me, sir?
Yes, sir, we can hear you properly, sir. Absolutely fine. Your voice is very clear.
হ্যাঁ শুনতে পারছেন না না বাট কেন আমার নেটওয়ার্কটা প্রবলেম করছে মনে হচ্ছে এখন কি শুনতে পারছো হ্যাঁ শুনতে পারছো কি নাই হ্যালো
We can hear you properly.
able to hear me just raise your hand or I will understand that
Sir, we can hear you properly.
Yes, sir. We are. You're audible, sir.
John, can you hear me
Yes, sir. Yes, sir. We can
Okay.
hear you. I think
that's fine so I'll start sharing then
Yeah.
And
Yes. Could you hear me? No. So you just start sharing, sir. I just did.
I think after Bristol stool chart, I think everybody have was there. So if there is a problem, then I'll switch off again. But this is celiac disease, food intolerance, lactose giardiasis, categorize room diagnosis, psychological influence of the disorder, psychological abnormality and physiological abnormalities both have to be taken into consideration. Those who have constipation predominant or diarrhea predominant, bloating or pain, depending on the symptom, you have to treat accordingly with the first line, second line, or future treatment which are in experimental mode now. Eloxybistat is commercially available. So 5S3 antagonists in IBS, the ramoxicillin is the molecule. So clinical evidence of ramoxicillin and IBS, there are 3 studies which have been quoted here. WGO guideline September 2015. Ramoxicillin should be effective in IBS diarrhea and appears to be devoid of serious adverse effects. There is a second Asian consensus on IBS, and that shows that the second Asian consensus ramoxicillin showed significant improvement in global IBS symptom, has high grade of evidence. Ramoxicillin is effective in IBS with diarrhea and IBS with a mixed stool pattern. Its effectiveness is supported by high quality data. Again, in emerging global evidence, effectiveness of ramoxicillin is diarrhea predominant IBS. This is the Japanese study as well as American gastroenterology. That is a very latest topic in February 2021. Ramoxicillin may be the most effective drug in the management of IBS. Again, in British Society of Gastroenterology guidelines shows management in April 21 that ramoxicillin is likely the most efficacious for IBS with diarrhea. Quality of evidence is moderate to high. So that means ramoxicillin is an emerging molecule and very commonly used because we use this as a once daily preparation. How it acts? Ramoxicillin hydrochloride is highly selective, long-acting 5S3 receptor antagonist. Look at this 5S3, this sodium channel. 5S3 helps in sodium channel that if the synaptic cleft is blocked, so that means no sodium is going inside. This is how 5S3 receptor antagonists act. Normally 5S3 receptor makes the permeation of sodium. If the antagonists are there, the sodium cannot enter inside the cell. Similarly, serotonin has got importance in greatly related to GI motility, secretion and sensation. How stress is important? Stress increases the serotonin, increase intracolonic pressure releases serotonin. That relates to GI motility, secretion and sensation. So ramoxicillin helps by a 5S3 receptor on the enteric nervous system as well as a receptor on the afferent neurons. So by blocking the afferent neurons, the intestinal oxidative transmission to CNS causing abdominal pain is taken care of. By acting on the enteric nervous system induces the acceleration of the intestinal tract. So it prevents this. So by prevention of this, the acceleration of the transit is not there. So diarrhea will not be there. For oral use, the usual dosage is adult 5 microgram of ramoxicillin once daily. The dosage may be adjusted according to the patient's symptom. The maximum daily dose is 10 microgram, which is tolerable. I'll tell you the comparative data: 1 microgram, 5 microgram, and 10 microgram. Before the implementation of the dosage adjustment, patient symptom should be observed for 1 month. If frequent changes in symptom occur, dosage adjustment should not be implemented. There are clinical evidence of ramoxicillin and IBS. A randomized double-blind placebo-controlled trial effective of novel serotonin receptor antagonist ramoxicillin in both male and female Japanese patients with a diarrhea predominant IBS. Study design was a double-blind placebo-controlled parallel comparative study. 539 patients were taken into consideration. 5 microgram ramoxicillin or placebo once daily for 12 weeks. This is the 3-month study period. Look at this. This white bar depicts the 5 microgram ramoxicillin group versus the dark bar separate the placebo. So as compared to placebo, there is definite improvement with the ramoxicillin group. when you are given for 3 months, at the end of final point also, the ramosetron group have got a better improvement of diarrhea as compared to placebo. So monthly responder rate of patient reported a global assessment of relief of IBS symptoms in male. Look at this, month 1, month 2, 3 month and final point. Again, in the placebo group and the 5 microgram study group. The 5 microgram study group has shown definite improvement as compared to placebo. This is the monthly, this is the weekly, this is the monthly responder rate of patient reported global assessment of IBS symptom, month 1, month 2, month 3, final point. Every month this shows that there is some improvement and definitely marked improvement as compared to placebo with ramosetron. So this is the study which showed the placebo, that dotted bars, empty bars suggest empty round bars are placebo, and dark bars suggest the 5 microgram. Definitely weekly responder rate was better. So conclusion, ramosetron hydrochloride 5 microgram was better as compared to and effective, well tolerated in treatment of abdominal pain, discomfort, bowel habits in patients with a diarrhea predominant IBS. This is a study 2, a title of phase 3-2 trial of novel serotonin antagonist in Japanese male and female with a diarrhea predominant IBS. Study design was a double-blind, placebo-controlled parallel group comparative study. Again, 418 subjects were taken into consideration, 109 subjects with placebo, 105 were 101 microgram, 103 was 5 microgram, and 101 was 10 microgram. Look at these, all 3 doses, 1 microgram, 5 microgram, the maximum tolerable dose 10 microgram has been taken into the picture. Look at this placebo, 5 microgram, 10 microgram. Looking at the 5 microgram and 10 microgram, there is not much difference between these two. So you can jolly well just give 5 microgram of ramosetron and with a good result. The monthly responder rate of patient-reported global assessment in IBS was good with 5 microgram of ramosetron. Also, the difference of the responder rate comparison placebo group was in males, similar in males and females. As for safety, there was a tolerability at doses of 10 microgram, but we use standard dose, that's a 5 microgram, but you can go up to 10 microgram. So ramosetron is an effective, well-tolerated treatment, not only for females IBS patients, female IBS, but also for male IBS patients. Normally, when we have the molecule, that novartis molecule, which is only for predominant IBS, and now we see that this molecule acts for male as well as female patients with IBS and diarrhea. This is the study 3, ramosetron efficacy in female IBS diarrhea patients. And enrolled 576 female outpatients. They were randomized to 2.5 microgram or placebo once daily before breakfast for 12 weeks after a 1-week baseline period. This came out to DDW 2015. Responder rates favoring ramosetron were significant by second week. Monthly responder global symptoms were significantly higher for ramosetron than placebo. So that means increasing over the course of the trial. This is 50.7% versus 32. So ramosetron was definitely effective in female with IBS. So daily average scores for Bristol stool form scale was significant by second day. The favorable change in stool frequency was greater with ramosetron than for placebo. Ramosetron at 2.5 is effective in women with IBS. Normally we recommend 5 microgram. For a woman, 2.5 microgram is also very effective. So what about other treatment? Ramosetron for IBS diarrhea, but for pain, we use sometimes directly acting smooth muscle relaxant like mebeverine, anticholinergic, hyoscine, simetropium, clinidium bromide, sometimes calcium channel blocker like otilinium or spelling mistake otilinium, this is otilinium bromide. So antispasmodic, the mechanism, look at the spasm, how if the colon gets spasm, they get segmented, the stool, that the constipation. If there is a problem with the calcium, like calcium with calmodulin, light chain kinase activation, like myosin goes to myosin P and actin causing contraction. So myosin P, that phosphatase goes into myosin again and acts with the myosin P, myosin phosphatase. So antispasmodic or spasmolytics, directly acting smooth muscle relaxant, inhibits excessive smooth muscle contraction in GIT. by lowering calcium in smooth muscle contraction, and anticholinergic like antimuscarinic have reduced it, they limited the pain, reduces excessive motility, as well as reduce motility in sigmoid colon. That is the predominant site of pain in patients with the IBS. Antispasmodic suppress the contractile response to stimulus like stress or meal. That is the reason why we advise them to take before meal, half an hour before meal. Mevaverin also has been used just before meal to prevent abdominal spasm and pain. For reduction of sigmoid motility in response to fatty meal, used for acute exercise. For example, postprandial pain is one of the factors which has to be taken care. That's the reason why you have to give mevaverin before meals. The safety and efficacy of sustained release mevaverin was compared to standard plain mevaverin capsule in treatment. Why standard versus sustained release? Sustained release you have to give twice daily. Standard dose you have to give 3 times daily. And they have taken 60 patients suffering from IBS. The score of at least 44 on crude scale were randomized into a 2-period crossover trial. Look at this. Each treatment period tested and the patient took mevaverin plain 135 microgram, 2 capsule TID, or mevaverin sustained release 200 milligrams, that's a sustained release, 2 capsules BD. After 6 weeks of each treatment, both treatments were regarded as effective or very effective by the patient as well as the investigator in more than 80% of cases. After 3 weeks of fast treatment, the disease score was rated light in 73% of patients with both medication. After 6 weeks, 9 patients, that 33 patients were symptom-free with mevaverin plain and 18% with mevaverin SR. So, considering the clinical improvement, more than 70% of all patients had improved after 3 weeks of fast treatment. An additional improvement was reported in 13 patients with mevaverin plain and 10 patients with mevaverin sustained release after next 3 weeks. Abdominal pain was still present in more than 50%, but it is lesser intensity or lower intensity as compared to baseline. So that is very effective in pain predominant. So mean scores for efficacy were very similar for both treatment after 3 to 6 weeks. Statistical comparison of all scores between the two formulas did not show any significant difference. So very few adverse effects were noted and causal relation with the study medication was judged as improbable or definitely unrelated. Compliance was close to 100% for most of the patients. The result of the present study indicates that the mevaverin sustained release capsule provide equivalent efficacy and tolerance to mevaverin plain. Why sustained release? Because the compliance is better. If you ask someone to take 3 times a day, it becomes difficult because in the office hour he forgets to take his mevaverin. So if you take twice a day, the compliance becomes better if you are giving a sustained release preparation. So, for pain, bloating, particularly when symptoms are exacerbated in meals, mevaverin is good. In clinical practice, antispasmodic, anticholinergic are the best used as needed basis up to 3 times per day for acute attack of pain or before meals when postprandial symptoms are present. So, coming to the brief, your concise diagnostic evaluation and prompt institution of symptom-guided therapy can help alleviate the pain and suffering of experience. And by experience of the patients with the irritable bowel syndrome, so our aim is to alleviate the symptoms or symptom-guided therapy is crucial. So this briefly I'll talk about rifaximin therapy because rifaximin usually, because previously used to think that rifaximin has got no role in irritable bowel syndrome, but nowadays we get more treatment in patients with constipation. If someone gets diarrhea, gets rifaximin, that's fine, that's acute diarrhea, is good. But patient with irritable bowel syndrome, especially post-infection form of irritable bowel syndrome without constipation, this is the original article that came in 2011. And what is the dosage they use? The 2 identical designed double-blind phase 3 placebo-controlled trial that target 1 and target 2, 550 milligram placebo at rifaximin at dose 3 times a daily for 2 weeks and followed for an additional 10 weeks. Look at this, randomization, primary efficacy, and at the end of period, end of study. 10-week follow-up, no study medication were used at the end. So proportion of patients who had adequate relief of global IBS symptoms for at least 2 of the first 4 weeks of the treatment. Secondary endpoint were the proportion of patients who had adequate relief of IBS related to bloating. So other secondary endpoints they considered as abdominal pain and stool frequency. So out of 1,260 patients who are enrolled in the studies were conducted in parallel from June 2008 to 2009, so almost more than 1 year. More than 90% of patients completed the entire 12-week study. Rate of adherence to the study drug defined as the use of at least 70% of dispensary. If someone is taking in the group of 70% of the tablet, that means he was adherent, was at least 97%. That means the adherence was not a problem with this molecule. This rifaximin is not observed, is basically a locally acting type of antibiotic, so there is not question of resistance with this. Significantly more patients with rifaximin group than placebo met the criteria for primary endpoint, and in target 1 as well as target 2 studies, 47% but 31.7% had 2 studies combined. So this is not only that, how the primary endpoint was weekly global symptoms. Look at this statistically significant difference. Daily global IBS symptoms, again statistically significant, P less than 0.001. Similarly, adequate relief of IBS related bloating, that was pain. This is bloating. Again, more patients in the rifaximin group than in placebo met the criteria, and adequate relief of IBS related bloating, or at least 2 of the first 4 weeks were seen, and again statistically significant difference. So daily IBS related bloating, weekly IBS related bloating, this is again efficacy outcome target 1 and 2, those shown improvement. Relief of IBS related abdominal pain, loose or water stool, definitely, because as you know, loose and water stool definitely is going to be.
Hello. Hello. Santosh, could you hear me? Hello.
Yes, Dada, yes.
Sir, I could not hear, sir.
No, sir is freezed.
Okay.
Sir, connection is lost, I think.
Maybe call kariye, sir.
We lost him.
We lost actually, sir.
Yes.
Maybe some connection error.
Yeah. Hello, sir got disconnected. He is trying to connect him. Shekhar, are you present? There is a quite bit connection problem.
I told you earlier also.
He is trying from the mobile.
And this hotel is far approach, far from Guwahati.
Okay. So we finish. It is almost 8 o'clock. Maybe 10 minutes, 5 to 10 minutes. We finish. Okay, team, could you call the doctors? Because we have in 5 minutes, then the question answer will be there. They can have the question answer.
Yeah, sir has joined, I think.
Sir has joined?
Yes.
Yeah, sir has joined. Sir, yes, sir. Yes, sir.
Can you hear me now, Chayan?
Yeah, I can hear you. Could you
Yes,
hear
I'll
me?
share.
Could you hear me, sir? Could you hear me, sir? Unshare, please unshare. Could you hear me, sir?
Chayan, can you hear me?
Yes, sir. Yes, sir.
Okay, I'll just take up my audio here and I'll see.
Yeah, could you hear me, sir? Could you hear me?
Yeah,
Okay.
I hear you. Now I'll just start sharing this.
Yeah, one thing you do, sir, you can also switch off your video. So that could be the good transmission. I think so. There is a problem of the connection. So you can switch off your video and you can discuss.
Okay, so you can see last few slides. Durability of the response on the basis of weekly assessment.
Yeah.
Analysis was done, and I'll just tell you that this analysis shows some improvement in patients who are on rifaximin. Similarly, the analysis of monthly response was evaluated, and they shows there is improvement, P statistically significant, less than 0.001 in two studies combined. The safety profile of rifaximin was similar to that of placebo, and these two studies showed that treatment with rifaximin at dose of 553 times a day for 14 days in terms of IBS than the placebo for up to 10 weeks after completion of therapy. So I think this is my end of the slide. This is the concluding slide. With this, I must thank you for your patient hearing. There was a lot of technical hits, so there was a problem there. So I'll just stop sharing and.
Yes, sir. Yes, sir. There is no issue, sir. Throughout the session, it was very nice. Like you have covered all the points regarding that IBS, right? And you have given a few case studies also you have discussed. So I can see, sir, few questions on the chat box, right? So first I take one question. Sir, could you hear me?
Yeah, I can hear you.
Yeah,
I can hear you.
So the first question is how to differentiate between IBS constipation and functional slow transit constipation. How you can differentiate?
Functional constipation is called slow transit constipation. Because if there is a problem in differentiating, because already I have mentioned that certain criteria should be fulfilled to make it a IBS constipation, and more than 25% of that have that Bristol stool chart showing 1 or 2 cell constipation.
Mm-hmm.
That is very characteristic about Indian scenario. That should be characteristic 1, 2, 3, and to tell this is slow transit constipation versus IBS, unless there is other IBS like stool consistency or form of stool, pain association with stool, then pure constipation, they don't have pain as we get in IBS. So constipation with pain, it makes an IBS diagnosis more. If you think of a slow transit constipation and if you cannot make a conclusive remark, then whether it's a slow transit constipation, you can do a siege markers. You can give some radiopac markers and see if there is more than 50% of the radio markers are lying in the small intestine or in the right colon that don't come into the sigmoid colon. So in the radiopac marker study can tell you whether it is a slow transit constipation or a functional constipation.
Okay, so the question that I'm into, so the full question is the management same for the both? Means the IBS
constipation. For pure constipation, pure constipation, you can use different type of, for example, in a child, we don't use fibers. For children, especially we avoid fibers. What if you have got constipation, we tell lactulose as the preferred drug. Sometimes you can give polyethylene glycol. We don't use irritant purgatives, and we, for an adult, not only fibers, you have to take plenty of fluid. Vegetable, fruits, vegetable, and patient come back to us that, sir, I am taking a lot of water, but I am still constipated. But just water will pass through your urine. That will not change your stool bulk or formation of the stool. So you have to ask them, not only that, along with that, you have to some form of exercise. Because if you know that the exercise is definitely has got a colonic motility or improvement of the colonic motility. So exercise and fibers. So there are two types of fibers. One is a soluble fiber, other one is insoluble fibers. If someone has a bloating as primary complaint like gaseous distension, because if you give insoluble fibers, they have got the problem of the bloating. If you give soluble fibers, they don't have that much bloating. And because as you know, lactulose is very sweet and they can have bloating as it is, lactulose can have bloating. So you have to individualize the patient. If someone has got bloating or no bloating, if someone is child, someone is adult, depending on that, whether you have to give irritant purgative, you have to give Sagrada, Senna, Dantron, depending on that, you would have to decide.
Okay, sir. Soluble fiber, which are the most soluble fiber you say that you use in a practice? Do you use it in the practice? Soluble fiber.
Soluble fibers nowadays they are commercially available because there are two things: fructooligosaccharides, inulin, etc. that are mostly used as prebiotics. That is available with a combination with certain companies have come with lactulose and lactulose along with, because when they are added to water, it must form a gel. It's not a powder preparation; it's a form.
Okay. Sir, next question is how IBS can be differentiated with the celiac disease.
IBS can be differentiated from
celiac disease. Celiac disease.
Okay. Celiac disease mostly, usually there's a malabsorption is a problem. They are usually undernourished, low birth weight, and they have got some bone problem, other forms of malabsorption problem. So to make a diagnosis, unless patient has got diarrhea is a predominant manifestation of celiac disease, and in IBS there could be diarrhea and IBS. So to make a diagnosis, you have to do a celiac serology, tissue transglutaminase, TTG, IgA, TTG, as well as celiac body antigliadin antibody can be done. Sometimes you end up doing intestinal biopsy like duodenal biopsy to look for villous atrophy in patients who have celiac disease. So these are the things, unless and finally, if you don't get diagnosis, you can ask them to take a gluten-free diet. If you are getting better with a gluten-free diet, that makes sometimes a suspicion that could be a celiac disease, and you finally complete your serology by TTG, and you can do endoscopic biopsy to look for.
Yeah, sir. The question is, could you hear me, sir? Yeah.
Yes, please.
Yeah, sir. How long you prescribe ramosetron? Means how long you give to the patient?
Ramosetron molecule is not very much used in our country now because it has recently been approved. So what we are doing at the standard study, they show that they have given for 3 months, 12 weeks study period. And after the study period is completed, they have observed for another month and whether this effect is persistent or not. And they have found that the persistence of the effect after stopping the treatment. So this maximum duration of the study so far the protocol shows it's 12 weeks.
Sir, if you'd like to sum up in your total discussion, you have given a comprehensive discussion on IBS. So what could be the take-home point for the physician or in the management of IBS? So could you give a few sum up points for them?
Yeah, the treatment of IBS is again individualized. There is nothing tailor-made that you have to do for IBS. First thing for the IBS treatment is reassurance, because whenever they come to it, because of the last hope, they have been seen by a primary physician, secondary physician, finally they have come to a hospital or a tertiary clinician to make their treatment better. So if you get you lose your nerves from the beginning, then it becomes difficult. You have to reassure, counsel, and think. Sometimes at the end you may end up with giving some antipsychotics or depending on the antidepressant SSRI and SNRI, and it is not. It has to be individual because someone may have constipation as the predominant, someone has diarrhea, someone have pain as the predominant. You have to individualize, and so most important thing is you don't have a generalized treatment for IBS. You have to treat individual as individual itself, how you deal with this.
So the same line, the question is the same line. I say I'll not take the brand name, but there is this ramosetron. Is there a chance of relapse of IBS symptoms? Once you manage with the ramosetron, is there a chance of relapse of the symptoms of
Yeah,
IBS?
already I have said that they have observed 1 month following that, and they have not any relapse.
Right. So, audience, any question? Any question? You can type in the chat box. So we have almost 35 to 40. I think so. I can say that 40 people was live. Now it is a 23. Right. So any question, audience? Could you post so our speaker can answer your question? Okay. So you can also post your question in the chat box. Yeah. So it is, sir, very nice interaction, the nice kind of a webinar we had, right? On the
I have
IBS.
attended from Guwahati because of this network.
Yeah,
problem.
yes, I can
Now I have
understand.
my mobile, that Jio.
Yeah,
So
I can understand, sir. That's a, but sir, I salute your intention. I salute that even you are in the Guwahati that you'd like to do kind of a webinar on IBS, right? And being an IBS driven company or being an IBS management portfolio. So it's our pleasure to have you as speaker. So we are approaching to the closing, right, sir? Santosh, could you share the closing slide, please? Yes. Yeah. So good evening. On behalf of Jaidas, I would like to thank all of you for your active participation. I would like to thank Dr. Jyoti Ranjan Mohapatra for his wonderful presentation. It is indeed our privilege to listen to you, sir. Last but not the least, my thanks to entire participating clinician without whom the event would not have been possible. It goes without saying that we will continue to rely on your affection and support now and hereafter. Thank you and have a great weekend ahead.